Not a question from yesterday. Question from tomorrow. Do you have any questions about the questions yesterday? The physiology ones. There's not the anatomy ones. These descending aorta, aortic arch, these things are. I don't know anatomy. I have no idea.
No, you do.
The one that be careful, don't put the needle there because the carrot is here. That's
Sean, you're slacking, bro.
Okay. Take a look at that question, read it carefully. Don't rush. Okay, we shouldn't take more time or less time than the necessary time. So to answer that question, okay, we're going to use one hand. We're going to say 1 or 2 or 3 or 4. What do you think is the correct answer? Okay. So,
Actually, all of them.
there are
So many different, except for
There are several students. I think most students say heart rate, but some say blood pressure diameter, and some say ejaculation. First of all, what is the question asking? How can you translate that question? Which of the following functions what?
That where one affects the sympathetic, it affects in the reverse in the parasympathetic.
It's more or less like which of those functions is affected reciprocally, okay, at the same time by the sympathetic and parasympathetic. If I increase one, something is going to happen. If I increase the other, something the opposite is going to happen. And remember, we have there some functions that are only functions of the sympathetic nervous system. For example, norepinephrine is something that is a function of the sympathetic nervous system. Blood vessel diameter is a sympathetic nervous system function. You increase the frequency of the firing, you will have constriction. You decrease the frequency, you have dilation. There is no parasympathetic activity, or at least not reciprocal. Okay, you don't need to increase the parasympathetic to dilate the blood vessel. You simply need to stop the sympathetic stimulation. Remember what happens in Horner syndrome? You cut the sympathetic innervation to the blood vessels of the face, boom, they open up and we have redness and water on the face. Then we have ejaculation, like sympathetic nervous system. Okay, there is no parasympathetic will participate in erection, not in ejaculation. And sweat production. Okay, this is, remember the exception we mentioned yesterday. It's a sympathetic function, but these postsynaptic neurons, postganglionic neurons produce acetylcholine. But it's a sympathetic function. Okay. Now, heart rate, the sinoatrial node, and the AV node, they are innervated by both sympathetic and parasympathetic. And depending on who is releasing more of the neurotransmitter, the heart rate is going to be faster or slower. Okay, this is a question that I didn't create. Okay, I wish I had. But I simply entered in Google and typed physiology autonomic receptors quiz. And there are a bunch of links there. Okay, you have several, and you can test what you study. Okay, everybody will discover what is the best way to study. Some people prefer to study in a group. Some people prefer to study alone. Okay, that's something that is very individualized. It's like shampoo. Like food, what food you prefer, what type of restaurants. Okay, where you prefer to go, to the beach, to the mountains. Something very individualized. Then if you want to join a group for clarify something, to clarify different things, that's okay. But one of the most important things is, did you learn while you were studying? Because sometimes we read the same thing 10 times and we repeat from memory, by heart, okay, pages and pages of a book, but we have a question and we don't know the answer. Maybe that doesn't mean that we don't know. Okay? Maybe if I tell you, okay, explain me the conduction system of the heart. Explain me what happens when there is a hemorrhage as a response. And we have a conversation and you are able to explain. That means you know. But one thing is explaining in a conversation, and another thing is answering in a question when you have a minute. Those are two different things. So after you study, you need to know if you are prepared to answer questions, okay, or this type of questions. Okay, and then of course recognize the concepts when you are in the exam. So let's continue, okay, with our fast computer. We were talking about receptors in the sympathetic nervous system. And don't forget that you're studying this more for pharmacology than for physiology. Okay, so this is something that you need to retain. It's not that, oh, I already did that exam, I'm not going to see that anymore. Okay, you're going to need that in the future very, very, very often. Okay, so there are different types of adrenergic receptors. They are a type of receptor that we call G protein coupled. Okay, they are gonna, the activation of the receptor, the binding of epinephrine, norepinephrine to the receptors will activate a second messenger. Typically the alpha 1 and the beta receptors 1 and 2 are excitatory, and the alpha 2 receptor is inhibitory. Okay, so epinephrine will bind to them. And for example, alpha-1 receptors will produce vasoconstriction. Alpha-2 receptors is going to produce vasodilation. Okay, sometimes in order to prevent excessive constriction, and sometimes just in order to regulate the blood flow. Where do you want the blood to go? Let's say we just had lunch, and we are at home watching a concert, doing digestion. So we have a lot of blood going to the digestive system, and we don't have too much blood going to the muscles. What for? Okay, we need blood there for the digestion. Suddenly there is an emergency. We need to run away from that place. We need to redirect the blood that is in the intestines to the muscles. So I activate the sympathetic nervous system, fight or flight. That will stimulate alpha-1 receptors at the level of the GI tract, producing vasoconstriction in the GI tract, and the same epinephrine is going to activate alpha-2 receptors in the muscles, in the blood vessels in the muscles, opening them up. Notice that the same epinephrine that normally we use to produce vasoconstriction, okay, when someone is bleeding, for example, to prevent bleeding, if you stimulate alpha-2 receptors in the arteries that goes to the muscles, will produce dilation. So we redirect the blood that was involved in the digestion, we send it now to the muscles, and we make sure that the muscles, the brain, the heart, will have enough blood for the fight or flight response. And that's how we shift the blood from one part of the body to another when we need to send the blood to different places. The emergency is over. Epinephrine levels go down, and now the alpha-2 and alpha-1 receptors are not going to be stimulated that much. So we now stop the circulation into the muscles and send the blood back to the digestive system. Okay, so The function is to inactivate the functions that are not needed during the fight or flight response, like reproduction, digestion, immune system, all the things that can wait. There you have another diagram very similar to the first one that we showed you with the divisions. Here you have more details about the anatomical components. Okay, the first diagram that we presented was a very simple one. Now you have the two divisions, parasympathetic, sympathetic, with more specificities. For example, the location of the ganglia. In the sympathetic, you have the celiac, okay, the superior and inferior mesenteric ganglia, okay, and all of the organs that receive a sympathetic innervation from them. Okay, you have below the nerves that go to the different organs in the pelvic cavity. In the case of the sympathetic, there are some sympathetic nerves that go there, you see, to the uterus, ovaries, genitalia, bladder, kidney. They following the nerves that we call splanchnic nerves. It's a term that, it's a very old term, but it's still in use. Splanchnic. This refers to all the circulation and innervation of the pelvic cavity, lower part of the abdomen. Splanchnic nerves, splanchnic circulation. You can see that also at the level of the parasympathetic. You go to the lower part, the sacral part. You see the parasympathetic nerves are called pelvic splanchnic nerves, innervating, look at the organs, the distal colon, sigmoid rectum, okay, and also bladder, genitalia, internal reproductive organs. And then you can see that, just by looking at those diagrams, for example, we can, for example, create questions. You can play and create questions. Let's say someone has a lesion in the spinal cord at the level of L5. Okay, so there is no communication with the body. Okay, the brain with the lower part of the body. So we could ask, for example, which of the following will be affected by this? Okay, and we can say ascending colon, transverse colon, descending colon, rectum, and that would be the answer. Okay? Notice that the proximal colon receives innervation from the vagus nerve, but the distal colon, sigmoid and rectum, from the splanchnic nerves that arise from the sacrum. Okay, what else could we ask? Let's say someone has a lesion, okay, at the level, let's say above, let's say, for example, C7. Let's not go C7. Which of the following will happen? What do you think will happen? There will be a sudden increase in the heart rate or a sudden decrease in the heart rate.
And respiration.
Sudden increase in the blood pressure, sudden decrease in the blood pressure. Who can tell me and why? If you cut the spinal cord at C7 and the person doesn't die,
Sudden decrease.
why decrease?
Because the sympathetic damage sending out signals.
Very much.
And also respiration, right? Because
Yeah, but we are going to limit to one.
But
If you
C5 and
cut-
C6.
If you cut the spinal cord, okay, at the level of C7, for example, okay. Yeah, but remember sympathetic fibers travel down to T1, and then they arise here. They go up. So if you cut spinal cord here, C7, let's say, all the fibers from the sympathetic nervous system, from the hypothalamus that go down to the T1 level are going to be cut. So now the person has an unopposed parasympathetic stimulation. So the heart is going to receive only parasympathetic stimulation. The blood vessels are going to lose all the connection with the sympathetic. So suddenly they're going to open up. Okay, persons develop what we call a neurogenic shock. Suddenly. Okay, bradycardia, hypotension, and of course all the paralysis, no, as a result of the section of the spinal cord, transection of the spinal cord.
So that means even C1 will have the same effect?
Well, yes, but if you got the spinal cord at C1, that's...
You did.
You're not going to observe any effect. You just have to sign the death certificate. Okay?
Every C1.
So it's only being controlled by the parasympathetic.
Parasympathetic is going to be unopposed. Have a question?
Can you repeat that? The concept with that? Because you said
Go back to the... Yeah, I said C7 just to go as low as possible in the spine. Okay. Notice that the parasympathetic nervous system fibers start at T1. T1 to T2. That means that if you cut above T1, say it's C7, C8. Okay, the only thing that is going to be innervating the heart is the parasympathetic, which is slowing down. All the sympathetic nerves lose the connection with the brain. Okay? Where do we control the diameter of the blood vessels? From the hypothalamus that sends wires to the blood vessels. If you cut those wires, brain has no more way to control the diameter of the blood vessels. They are going to dilate suddenly. Okay? Because there are many types of shock, as we are going to study in pathophysiology. Someone starts bleeding, starts losing blood little by little. Maybe they are 2 hours with a hemorrhage. The blood pressure drops, until they are in shock. When there is a transection of the spinal cord, there is shock in 1 second.
Professor,
Okay, sudden drop in blood pressure.
but if you cut at C7, you would still affect everything below, right? Because you're
And
cutting
above.
there.
Normally when you transect, you have an injury, and there's going to be edema. That the edema is going to go up 2 segments above and 2 segments below. That's why if you cut at C1, people die, because the edema goes to the brainstem.
And if you cut at C7, since you said that
Well,
the
yeah,
fibers are going
I know
down,
what you mean now, yeah, with paralysis of the muscles and lack of sensation and incontinence and all that. And we are talking only now about the blood pressure. Remember when you have a multiple choice question, that is the universe. The question is asking you, which of the following will happen to the blood pressure, sudden drop?
no, but I was wondering if everything below would be affected, and if the fibers are going down to T1
Yeah.
and going up, would the
Everything
eye
is gonna be
affected as well? The eye? If
Yeah, of
it's-
course, of course, yeah. All the sympathetic nervous system is affected. Yeah, if you produce a lesion at that level, yeah.
So it's everything below the lesion, even
Yeah, all the sympathetic nervous system is going to be affected.
So we're
And here we have the summary of all these things we were talking yesterday about the preganglionic, postganglionic neuron, what neurotransmitters they release, what receptors are present. Okay, notice there you have on top the parasympathetic, okay, as it arises from the brainstem, and all the way down you have also the parasympathetic fibers that arise from the sacrum. Notice that there is no difference. These and these are the same. So you can study only one. Okay, you have a preganglionic neuron that produces acetylcholine to nicotinic receptors, cholinergic nicotinic receptors. Then you have a postganglionic neuron that releases acetylcholine. There are 3 types of receptors, M1, M2, M3. We don't need to understand the difference now. M1 is typically in the brain, M3 are the most abundant, but we don't need to enter into that now. Then we have the sympathetic. Before going to the sympathetic, let's go to the somatic, that is more simple. That is the one that controls skeletal muscle. You have a single motor neuron, okay, that arises from the spinal cord, that produces acetylcholine, okay, and acetylcholine is going to bind to receptors, cholinergic receptors, in the neuromuscular junction. Okay, it's like the saying that we study all the time. important thing here is that we have a single, okay, motor neuron arising from the spinal cord. Now, the one that is a bit more complex is the sympathetic. Notice that the preganglionic neuron produces acetylcholine that binds to nicotinic receptors exactly as the parasympathetic. That means when we smoke or we have any compound with nicotine, can be a patch, can be chewing gum, that will stimulate both sympathetic and parasympathetic at this level, the ganglionic receptors. And then we have the postganglionic neuron. Okay, notice that in this case we have acetylcholine binding to muscarinic receptors. You remember what that is?
Mushroom.
What is the example that we gave for this? This is not a mushroom. This is what?
Sweat.
I'm very nervous
Oh,
today.
increase
No?
sweat.
I'm very nervous.
Sweat glands.
Sweat glands. We are stressed. Oh, my feet are sweating, my hands are sweating. Oh my goodness, I'm nervous today. Okay, sweat glands, mostly the apocrine glands and the glands in the palms and soles, and the apocrine glands in the axillary and pubic region, etc. They are innervated this way. And then we have in the center, okay, the classic sympathetic pathway. Okay, the postganglionic neuron producing norepinephrine, not epinephrine, is norepi, that binds to alpha-1, 2, and beta-1 only. Norepi doesn't bind to beta-2. And the one below is the sympathetic stimulation of the adrenal medulla. Okay, the adrenal medulla is like a ganglion. You have a preganglionic neuron that binds or sends acetylcholine to these receptors on the cells in the adrenal medulla. And these cells, instead of releasing the neurotransmitter to a synapsis, they're going to release the neurotransmitter to the blood. That's why we call it a neurohormone, because it's a neurotransmitter that goes to the blood, like the hormones. What is a neurohormone there? A little bit of norepinephrine and tons of epinephrine. Okay, the adrenal medulla, one of the things it does is convert norepinephrine into epinephrine. Okay, that is going to activate alpha-1, 2, beta-1, and beta-2 receptors. Okay. And what do we need to convert norepinephrine to epinephrine? Who knows? That's tricky.
So that it could attach to the beta-2.
The epinephrine.
Oh, so what's that?
What supplement we need to convert norepinephrine to epinephrine? You know that? It's a vitamin.
Is that what?
Vitamin. Vitamin C. Is necessary. If we don't have vitamin C, that step is a bit complicated.
What was the answer?
Vitamin C.
Now here we have the actions that we get after we stimulate those receptors. Okay, alpha-1. You remember the actions of the sympathetic and fight or flight. Now what we have to do is try to separate things depending on the location of the receptors. Okay, alpha-1 produces mydriasis, is the one that opens up the pupils, ejaculation, vasoconstriction in skin, GI tract. Remember what I told you during the sympathetic activation, we don't need blood except in the muscles and in the brain and in the heart. The skin doesn't need blood. If I have a cut, I will make sure that I don't have too much blood there. I don't bleed too much. Okay? I don't need to be doing digestion or creating T cells and B cells. Okay? That's for moments of rest. Vasoconstriction in places that are not needed during the fight or flight response. Okay? And this relaxes the detrusor of the bladder, so we don't urinate. Okay? We need to stop the bladder from contracting. Alpha-2 makes a negative feedback on epinephrine release, so let me try to avoid too much vasoconstriction, too much of this stimulation. Reduces the aqueous humor production, And it's not that physiologically this is very important, but it's something that you need to know for pharmacology. When you are going to treat glaucoma patients, you are going to use drugs, okay, that will reduce the production of aqueous humor, okay, to try to reduce the intraocular pressure. So that's, they are more for the purpose of pharmacology than physiology. Beta-1, these receptors are in the heart, and they are the ones that participate in increasing the heart rate, okay, contractility, increases renin. Okay, that when we get to the kidney and the regulation of the blood pressure, we're going to know more about that. Okay, when you see that, those connections between the sympathetic nervous system and the adrenal medulla and the kidney, okay, when during this fight or flight response, we increase epinephrine production, and also we have nerves that go to the kidney, okay, to the juxtaglomerular cells to increase renin. Renin will increase aldosterone, okay, angiotensin, angiotensin 2, aldosterone, etc. And beta-1 also decreases salivation. Okay, then we have the beta-2. Okay, they will produce a vasodilation. Remember, we are gonna need blood in the skeletal muscle, in the brain. There we have, as we said before, the alpha-2. We didn't mention that on top. Okay, you can add it if you want there. Okay, we have the beta-2 receptors that lead to vasodilation in the skeletal muscle and the brain. And notice here, one thing. This is something that is only stimulated when we release epinephrine from the adrenal medulla, because the fight or flight, stress response, all these responses will have different levels. One thing is that we are at home and we see a roach, and we need to, oh my goodness, there's a roach flying or something. And another thing that is a fire or something really dangerous. If you see a roach flying, that's disgusting, but it's not life-threatening.
To some people it is.
Well, at least you need to move away, you know? But if there is something really, really, really life-threatening, okay, we need to send a lot more blood to the muscles, okay? And that's why we have this like step up, okay, by releasing epinephrine and increasing the vasodilation, skeletal muscle, brain. Beta-2 also in the lungs. Okay, you're going to have more applications clinically and pharmacologically for that. Okay, when you stimulate beta-2 receptors to produce bronchodilation in COPD, emphysema, asthma, bronchitis. Increases aqueous humor production, so you know what is a contraindication of beta-2 agonists? And you know why? If someone has increased IOP, glaucoma, and we give a beta-2 agonist, they're going to increase even more the IOP. So we better block them. Okay, we better block those receptors. Increases the release of glucose from the liver. And we have the M3 receptors, acetylcholine for the sweat glands. Here we have the parasympathetic, M1, M2, M3. And the first time I studied that, I said, oh my goodness, I don't have enough with alpha 1, alpha 2, beta 1, beta 2. Now I have also to learn M1, M2, M3. But then I said, oh my goodness, M1 is in the head, M2 is in the heart, and M3 is the rest of the body. No? It's not that hard, no? M1, M2, everything else. But it's not difficult to remember. So, what is the actions of the activation of these muscarinic receptors? Of course, if we block M1 receptors, that's not going to be very good. No? That's why when people have, for example, any cognitive disorder, Alzheimer's, or any degenerative disease, we have to try to avoid certain anticholinergic medication and certain antihistamines that cross the blood-brain barrier. You will hear many times, Benadryl is not good for the elderly. Of course not, because Benadryl crosses the blood-brain barrier and it's going to have these anticholinergic actions blocking the neural transmission in the brain. So they may fall, they may forget more things than usually. It's not that Benadryl produces Alzheimer's. Okay, it's that the symptoms may worsen with Benadryl. Okay, because I've heard, even, for example, I've heard even doctors, PCPs are, no, don't take Benadryl, that can produce Alzheimer's. I'm not going to take Benadryl because I need to drive. And I want not to have a hangover tomorrow. But it's not that it produces Alzheimer's. Okay.
So the effects would only last until the Benadryl is out of the system.
Yeah, that takes longer in the elderly as well. Because in a healthy person, maybe you wake up like, oh my goodness, I don't take that anymore. Then you have a coffee and that's it. But in the elderly, then maybe 2 p.m. Like,
Oh my goodness.
when are we going to go back to Miami? Then you have the actions of the parasympathetic, okay, meiosis, okay, participates in lens accommodation, increases lacrimation, bronchoconstriction, gastric secretion, acid secretion, salivation, peristalsis. And when you learn that, notice the following. You are not likely to have a question saying, which of the following is a function of the parasympathetic? Because you already have had many questions like that. Okay, and a researcher is developing a medication that blocks muscarinic 3 receptors. Which of the following will occur? If you block these, you're going to have broncho what? Dilation. Okay, by blocking the muscarinic receptors, we dilate the bronchi. So you know how to treat asthma now, not only albuterol, not only beta-2 agonists. We can use also can block muscarinic receptors. But if we stimulate the muscarinic receptors, then that's going to be a bad thing. What happens if we take anticholinergics? Are we going to have drooling or a dry mouth?
Dry
Mouth. Okay. And instead of asking that plain question, a physiology professor is complaining that when he's talking too much, the mouth gets very dry. Which of the following could you prescribe in order to prevent the dry mouth? Okay, and that's simply something that increases the salivation. Okay, so you can stimulate the acetylcholine receptors. But if the professor has asthma, you don't want to do that because you can produce bronchoconstriction. So you have to be careful. And this is the last slide here, and it has some concepts mixed there. Okay, because remember the purpose of this is that you don't have too many problems in pharmacology. Okay, here we have the actions of norepinephrine and epinephrine. Okay, on the right side you have an overview of the cholinergic system, acetylcholine. And on top you have the presynaptic neuron. Okay, on the left, the presynaptic, the post-ganglionic neuron that is releasing norepinephrine. Notice that norepinephrine will bind to the ones that are in the red box. Everything except beta-2. Norepinephrine is going to be reuptaken. That is a mechanism that we have to stop the action of norepinephrine, reuptake it. And then you have below the adrenal medulla releasing norepinephrine. Will go to the same place, and epinephrine that will bind to beta-2 receptors. You can block the action by using alpha blockers or beta blockers. You can increase the action of the sympathetic by using alpha or beta agonists, or simply by blocking the reuptake of norepinephrine. Okay, that is a mechanism. You can inhibit certain enzymes that are there, or you can force the neurons to make more and release more norepinephrine. On the other side, you have the release of acetylcholine. How do we stop the action of acetylcholine? Below there, you see in red, an enzyme that is called acetylcholinesterase that breaks down acetylcholine. Okay, separating a molecule that is called choline and acetate. Acetate is like vinegar that will dissolve here. The choline is going to be taken back into the synapses. We reuptake the choline and recycle it, make more acetylcholine. Acetylcholine will bind to different receptors, okay, nicotinic, muscarinic receptors. And we can use muscarinic agonists to directly increase the actions of this parasympathetic nervous system, or blockers, okay, to block the actions. So antagonists or direct agonists. And then we also can work on the activity of the acetylcholinesterase. If we increase the activity of the acetylcholinesterase, we're going to degrade acetylcholine faster, so we're going to reduce the parasympathetic activity. Okay, but we normally don't stimulate acetylcholinesterase. We normally medically try to inhibit the action of the acetylcholinesterase to keep it acting longer. Okay, we normally use reversible methods, okay, of inhibiting that enzyme. And there is a very simple way of inhibiting that enzyme, is applying ice to lowering the temperature of the area. Okay, you inhibit the acetylcholinesterase. If one day you feel like, oh my goodness, I'm so tired, I can't even open my eyes, put ice on your eyes. Oh my goodness, my eyes are strong now. Because you have more neurotransmitter. Okay, you have more neurotransmitter. Oh my goodness, I feel better, more relaxed, more. Okay. And well, then we have also irreversible inhibition of the acetylcholinesterase, for example, sarin gas, organophosphates, pesticides. That if someone has a poisoning with that, imagine all the things that someone may have. If you inhibit irreversible, okay, the acetylcholinesterase, all the acetylcholine that we produce stays there in the synapses. I think we are going to have a huge parasympathetic activation. People are going to be, what do you think is going to look like clinically? You can tell. But yeah, fatigue, of course, but tell me autonomic symptoms, like heart rate, blood pressure, salivation.
Low blood pressure, increased heart rate, bradycardia,
The heart rate will be decrease. What about salivation, lacrimation?
increased
There will be drooling, lacrimation. What about urination, defecation? Increase. What about intestinal motility?
increased.
So imagine a person with that, drooling, urine, increased motility, urination. I don't think they're going to have appetite. All that.
Doesn't it have faster?
Appetite has a lot of social and emotional components. Okay, so and you are drooling, and after you are in a terrorist attack with sarin gas or something.
Your question
Well, we
was,
go to McDonald's now? No.
the question you asked was if there's increased acetylcholine in the synapse, what would happen? What was your
When you
your-
block the acetylcholinesterase?
Oh,
Yeah.
okay.
So let's have a break until 11, okay?
Because one of the it's with as well, right? The acetylcholine.
Are you talking about myasthenia gravis? You give yeah, the myasthenia Let's say this is the pushing up, the pressing up. We normally produce like, let's say, 400 times a week. So we produce and we bind the receptors and most of your records degraded by it. We start breaking down the receptors. Now you have only and continue producing and most of it is degraded. We are going to have a material available for this. It's not the saturation, it's that maybe the one. How can I say? Let's say we produce 400 molecules and we break down normally 390 immediately. So we only have 5 of them. And we are going to buy here, but now we have this gone. Okay, we have only 5 left, but only maybe only one reaches that area. So you need to increase. What you need to do is try to slow down the breakdown of acetylcholine so the receptors that are available get the acetylcholine. That's why when you use ice, you lower the temperature. Lower temperature inhibits acetylcholine because acetylcholine works perfectly at one time. You lower the temperature and will break down acetylcholine.
I don't think you have any
There are. Selecting for that.
looking at this diagram, and sympathetic doesn't have M1 and M2.
Normally, the ones that we have are typically selected. If they are selected for everything. We don't have any selected for them to.
Okay, so sympathetic still, I guess, fine.
But of course the medication has to cross the blood-brain barrier. Even if the medication has affinity for M1, if it doesn't cross the blood-brain barrier. But don't worry about that. For us.
Okay, and then you said it's a single motor neuron from the spinal cord.
The affinity for the well, there is more than that. The nicotinic is simply a voltage gated substance, and the muscarinic is like a nicotine. That is bad.
And are they both cholinergic or no?
They bind to and they work differently. So they are classified. If you intend to buy them, this is not for us. Say the nicotine is called open iron chine, and the muscarinic is called because they activate second messenger and that's why we're not going to ask questions about that. Bind to acetylcholine. Okay.
Thank you.
I mean, I was wondering, like this is, she said this is and this is
para sympathetic.
and you can find this not as part of this is not
Four, right?
Well, this is representing can represent either So we have a real and that's the diagram. It's real body.
I mean, I kind of see with this diagram right here, it like comes up like out.
Yeah, it's outside. This is a part of it. And the pre-vertebral are here. More or less the same thing. Kind of real.
So they're actually on the vertebral column then.
So it's like para.
That's a para. So it's para, like right here. I don't know, if just for the image they're separating so large.
That's why when they have, for example, a lung cancer or a lymphoma, that's going to be destroyed. It's going to be damaged.
Yeah, I was just wondering because I couldn't like visualize it. Thank you so much.
I'm confused, you're saying if there's any damage to like because the way it goes down and up. So essentially anything so like even if I do like nine, like everything above and below, it doesn't really matter which.
No, because for example, the ones to the heart, they go here and up. Okay, the ones to the lung, maybe go here and up. No, the ones that go up are for the eye, that's it, for the heart. But the one for the, let's say the liver, that's here. So if you cut here, you're going to affect the heart, the lung, and the liver.
For example,
They don't go all the way down and all the way up. They go all the way down. Let's take this lens. Let's make this a lens. These fibers here, maybe they go down and they don't go up, one up. But the ones that go to the heart, they have to go up a little bit. The ones that go to the eye, to go up to the head. And enter the neck and enter the go up. Through this structure that you see here. Here, you can find the fibers that come from the thoracic spine and go to the eyes.
okay, yes.
Okay? Sympathetic innervation of the eye is the wire. Comes from the thoracic spine and comes from the hypothalamus, cervical, thoracic,
But then, so like if I cut off C5, for example,
you don't, unless you call the sympathetic chain. If you go here, okay, these fibers came here. No, wait. C5, yeah, C5 is about C. Yeah, if you got any cervical level, everything is going to be affected.
like if I cut C5, do I have to cut here or here?
If you got above C8, everything is going to be affected. There was a thing in the room. Yeah, no more white.
That's what I'm not understanding. I don't know why that happened.
This is C. Okay, this is E. Okay, this is hypothalamus, the brainstem. The sympathetic nervous system, neurons. It's the same guy, right? Let's say you want to open up the pupil. Starts here.
another that goes here maybe and goes there's another that goes here and goes to the lung. Another goes here and goes to the intestine, the liver, it goes here. Everything's going to be affected. All these wires that the heart is going to be affected, the lung, the intestine, the eyes. If you got here, only the liver and intestine will be affected, but not the other ones, because they already went out.
Okay.
In my house, you have the electricity, and here you have all the wires. Some of them go to the bedroom, then go to another bedroom, the living room, depending on where you cut. And then to one to the other. Because here,
Can you ask me a question to tell you? If I answer something and I'll tell you what happened.
do you mind? Like that is.
And I'll tell you if I understand.
Affects the liver. Oh shit, how did it like that? No, you said it's easy. And I saw her. So it's kind of like
Why do we have in the cultural level the level of what is the action of the sympathetic nervous system on the glucose levels? What it does in the liver? So sympathetic increases blood sugar level. If you disconnect the sympathetic from the liver, sympathetic cannot stimulate the liver.
yeah, I know.
Okay, let's move now into endocrine regulation. And notice that this presentation is not called endocrine system, it's called endocrine control systems. There is a slight difference. We are simply trying to understand the endocrine regulation of the body without going into, of course we are going to talk about endocrine glands, hormones, action, regulation, but this is not a comprehensive endocrine system presentation. There are some basic concepts that we need to understand before engaging in the study of hormones, endocrine regulation system. Okay, and Simply, we are going to be studying the interactions of several glands that we have in the body and several tissues that are located within other organs that typically produce chemicals that will go into the blood. Okay, there are different types of chemicals. Some of them are more proteic in nature. They can be tiny peptides or large proteins. And some of them are steroids that are made from cholesterol. So sometimes you have like a combination of them. A hormone is a chemical mediator, okay, that circulates in the blood. It's produced by endocrine gland, organ, or tissues. Okay, and will bind to receptors in distant organs, sometimes not so distant. If you consider some, for example, hypothalamus, pituitary, they are not so distant, they are very close. Okay, but anyway, the chemicals, the hormones travel in the blood. Okay, they will bind to receptors in some target organs, and after the binding of those receptors to those receptors, there is going to be a response. Cells are going to do something. They are going to start either dividing or producing something else, or will stop the production of something. Okay, and we're going to see how the endocrine system and the nervous system work together, okay, to facilitate homeostasis, to maintain homeostasis. The nervous system tends to act more in the short term, immediate action, and you need to do something immediately, very fast. And the endocrine system typically takes longer, so maintains more in a longer term homeostasis. Because imagine that we are in a rush, we are in an emergency, like we mentioned before with epinephrine. And we need to start making a hormone in the hypothalamus that stimulates the pituitary, and then the pituitary produces another, and that goes in the blood to find a gland that would take forever. No. So we need systems, some of them that act more quickly, some of them that maintain the actions in a longer time. And we have here some of the functions of the endocrine system. Okay, there are many. We start in the embryo, fetus, children, puberty, okay, teenagers, adults, pregnancy, lactation. Okay, we have many different functions. Okay, one of the first functions is produce the differentiation of the reproductive organs. Okay, depending on when the embryo develops. Okay, there is a primitive gonad that is the same for everyone. Doesn't matter if they are XY or XX. That gonad is gonna become either ovary or testis, and ovaries are gonna produce more estrogen, testes are gonna produce more testosterone, and that is gonna lead to the differentiation, okay, of the external and internal reproductive organs, and also of the brain. Okay, the brain is going to differentiate depending on if there is more estrogen or more testosterone during the fetal. Also participates in growth, development. Okay, children grow, develop during all the childhood and also during the puberty. Develops the secondary sexual characteristics. The distribution of the adipose tissue is different. Okay, the patterns of hair growth is different. Males, females, of course, the external genitalia, breasts, muscles, etc. Okay, coordinates the function of the reproductive systems, menstrual cycle, oogenesis, spermatogenesis, all these functions. And, well, we are going to try to focus more on the maintenance of the homeostasis. Okay, all the other functions, we are going to study them when we go to the reproductive systems. Okay, and, well, also participates in the fight or flight response and adaptation to emergency situations, not as fast as the nervous system, but also participates. For example, if we have a hemorrhage, okay, we mentioned before, if we are having a low blood pressure because of the bleeding, the nervous system is going to activate the sympathetic nervous system, that is going to produce vasoconstriction, it's going to increase the heart rate, it's going to try to elevate the blood pressure, but at the same time, we are going to have the release of antidiuretic hormone that will keep water in the body. We are going to have the activation of aldosterone. Aldosterone is going to retain sodium and water, contributing also to increasing the blood pressure. An antidiuretic hormone, okay, has different names. One of the names that is disease is vasopressin. Okay, vasopressin or arginine vasopressin. Vasopressin simply means blood vessels constriction because it has a double action depending on the situation of the body. Let's say we are having dinner and we eat a pepperoni pizza. We have a very high amount of sodium in the blood that is going to be detected by the hypothalamus, and we are going to produce a tiny bit of antidiuretic hormone that is going to simply tell the kidneys to retain water, okay, to try to dissolve the sodium in the blood. That's antidiuretic. But if we are bleeding, now the low blood pressure is going to make the pituitary release 10,000 times more antidiuretic hormone, and in that moment we call it vasopressin, because now the action that it's going to have is vasoconstriction in the entire body. It's a very powerful vasoconstrictor together with epinephrine, together with angiotensin II, trying to maintain the blood pressure in cases of emergency. So notice how they work together. Endocrine and nervous system trying to save the perfusion of the brain, which is the priority of the body. Let's compare the actions of the endocrine and nervous system. Okay, there you have some aspects. For example, the signaling mechanism, the language of the nervous system is the action potential. Okay, there are electrical signals, and then that will lead to the release of a neurotransmitter. So there is a chemical and electrical signaling there. In the case of the endocrine system, there is only chemical signaling, chemical messengers. Okay, the primary signal is the neurotransmitter in the nervous system, while it is a hormone in the case of the endocrine. Don't forget that there are some chemicals in the body that are called neurohormones. Okay, an example is epinephrine that we release into the blood, but it's released by stimulation of the nervous system stimulation. Now, distance traveled by these chemicals, very short in the case of the nervous system, the synapses. Okay, very long or sometimes short in the case of the hormones. You have the response time. Sometimes the response is going to be very fast. Sometimes it's going to be slow. That will depend on specific hormones, how they act. Okay, there are hormones, for example, that they bind to receptors on the cell membrane, they activate a second messenger, and you have the action occurring immediately. Let's say insulin binds to receptors on the cells, and the cells start taking in glucose immediately and storing the glucose. But in the case of the steroid hormones, that takes a while. In the case of the thyroid hormone, that takes a little bit of time too, because steroid hormones and thyroid hormones, they need to enter into the cell, they need to bind to receptors inside the cell, in the cytoplasm. These receptor with the hormone, they need to translocate to enter into the nucleus, in the nuclear pores. They need to bind to the DNA. They need to activate the DNA transcription, the production of messenger RNA. Messenger RNA has to go out, okay, and that will lead to the production of some proteins. But hormones act faster or more slowly. In the case of neural signals, it's always fast. Okay, and environment targeted. Okay, that you could say that enters into even the philosophical field, no? Endocrine only works with the inside. Is that true? Endocrine only regulates the inside of the body, and nervous system interact with the outside. We could discuss that, because if you enter into the field of pheromones, etc., you can find an interaction with the exterior that is unconscious for us, but it exists. Okay, but let's leave it like it is in the books. Don't want to enter into the philosophical part of medicine. Now here we have the classification of the hormones. We have a classification depending on the chemical structure, classification depending on if they are soluble in water or lipids. Okay, and we also have the classification into tropic, non-tropic, and we have examples of neurohormones. Okay, besides the one that we mentioned before, the epinephrine. Chemical structure. Okay, they are classified into peptides, a chain of amino acids that can be short and be longer. Okay. There you have many hormones. It's better to learn the other hormones, the ones that are not peptides, and then say, okay, the rest are peptides. Because the majority of the hormones are peptides. Many more. Insulin, growth hormone, many more. Now, what are steroids? Look at the name. Look at the name, steroid. It's present in the name of the hormone. Okay, cortisol, testosterone, estrogen, aldosterone, progesterone. We have the name there. They are made from cholesterol, like vitamin D, for example.
No.
Okay. And well, we have amines, are simply made of a single amino acid. Catecholamines, epinephrine, norepinephrine. Okay. You could include dopamine in the case of it's another amine, but it's not a hormone. That's why we don't include it there. But dopamine, which is a neurotransmitter, is also an amine. And well, we have thyroxine. We're gonna see thyroxine that is a little bit special for everything. So we have the amines, the steroids, so the rest of the hormones are peptides. Shorter, longer peptides. So the ones that are not there, they are proteins, they are peptides. Then we have the solubility. Some of them are lipophilic. When we say lipophilic, we are also saying they are hydrophobic. They love to be, okay, dissolving adipose tissue in lipids. And I say adipose tissue, so you understand that this will have implications later. You're going to have, not in physiology, but in pharmacology, you're going to have problems to solve. The person has this body mass index, the percentage of body fat is this, the percentage of body water is this. They are administered a medication, and you have to know it's hydrophilic, hydrophobic, lipophilic. Okay, what will be the distribution of the drug in the body? Oh my goodness, the body mass index, the percentage of body fat, the dose of the medication, and you can calculate the distribution of anesthetics of different things. And there you have steroids and thyroxine are lipophilic. Notice that thyroxine, thyroid hormone, is made of an amino acid, so it's proteic in nature, but is lipophilic. That has an implication. They are welcome into the cells. They don't need to bind to receptors on the cells. Okay, they are lipophilic. They pass freely through the cell membrane. Okay, steroids and thyroid hormone. Hydrophilic. We have the peptides and amines except thyroxine. Okay, they must bind to the cell membrane receptors. They have to knock at the door. They are not welcome freely. They knock at the door, someone is going to go out. What do you need? I need you to start making this hormone. Okay, I will tell the nucleus. That's the second messenger, the action of the second messenger. Now there we have the classification into tropic and non-tropic. Okay, and it simply means, or it's telling us if the hormone, when it binds to the target cell, will trigger the release of another hormone. For example, from the anterior pituitary, we produce thyroid-stimulating hormone. I will go in the blood, bind to the thyroid gland cells to trigger, stimulate the release of thyroid hormone. That is a tropic effect. Now, thyroid hormone is going to go out, and it's going to go to many cells in the body, stimulating the metabolism of the cells. That is not a tropic effect. Okay, that is not leading to the production of any hormone. Okay? In the case of another anterior pituitary hormone, prolactin. Do you think it stimulates the release of another hormone when it acts on the target tissues?
No.
No. It doesn't stimulate an endocrine gland. It stimulates an exocrine gland to produce milk. Okay, so it's non-autonomic. That's the classification of that. And in the pituitary, we have the examples of oxytocin and vasopressin that are classified as neurohormones simply because they are made in the hypothalamus. Okay, there are some hypothalamic nuclei that produce these hormones, and they are stored in the posterior pituitary, what we call the posterior pituitary, and from there they are going to be released.
So the hormones like FSH are both tropic and non-tropic?
The ones that stimulate the production of another hormone are tropic.
So that one would be, wait, so it would be both or would it just be tropic?
Which one?
FSH.
What do you think? FSH, follicle stimulating hormone, stimulates what?
Follicle production, and it stimulates also
The facilitates or participates in estrogen production,
So
inhibiting it's a tropic hormone. Okay. If it stimulates the production of another hormone, yeah. Okay. Do you see the?
Physical hormones when they cross the membrane.
When they cross what?
The vascular membrane, do they need a messenger to be inside?
No. When they cross freely the cell membrane, they don't need a messenger. They bind to receptors inside the cell, and the receptor translocates into the nucleus with the hormone, and they bind to DNA and activate transcription, translation, all that. Let me make let's say this is the brain. Okay, this is the brain. And we're going to represent here the hypothalamus. It's going to be huge. The hypothalamus is actually tiny, very small. The hypothalamus normally has like an extension. It's like a finger that goes down. And that is what we call the posterior pituitary. But that is actually part of the hypothalamus. And we call it posterior pituitary. Because remember, the mistakes that people made centuries ago, because they didn't know, we still respect them. Okay, we still maintain those names. But here we have some neurons. Okay, this is the neuronal body. This is the axon, and this is the axonal end. That's why we say posterior pituitary hormones are made in the hypothalamus and stored in the posterior pituitary and released from there. It's exactly like any other neuron works. They make the neurotransmitters in the body, in the endoplasmic reticulum. They transport the neurotransmitters along the axon, and they store the neurotransmitters in vesicles there in the axonal end to release them whenever it is necessary. It's exactly the same thing that is happening here. What is the anterior pituitary? This is actually tissue from the nasal cavity. Okay, during the embryonic period, some cells in the nasal cavity get tired of being there. I don't like this place. Okay, too much noise, too much air, very wet, and they start traveling back. Cells migrate back from the nasal cavity, and they attach here. But this is glandular tissue, while this is nervous tissue. That's why the posterior pituitary is called neurohypophysis. I don't know what I did there. Hypophysis, and the anterior is called adenohypophysis. Adeno means gland. Adenoids, think in the Greeks. What are those glands that grow in the nose? The adenoids. No. You also have an adenohypophysis. It's a gland that moves back and attached to the extension of the brain, which is the posterior pituitary. And that's why the anterior pituitary makes hormones and releases the hormones into the blood. It's a gland. Okay, the posterior pituitary is simply nervous tissue, neural tissue. It's an extension of the brain. Like the optic nerve. Do you know that the optic nerve and the olfactory nerve are really not cranial nerves? They are extensions of the brain. They don't have Schwann cells, they have oligodendrocytes. We have neurons inside the eyes. The retina has neurons. When you do the fundoscopic exam, you're actually looking at the brain. Okay, the retina is part of the brain. It's like the brain goes out to see what's going on outside. So that's the difference between the anterior and posterior pituitary. Let's see if this one should work. Computer. And here you have more details. Okay. For example, you have the chemical composition, okay, amines, peptides, proteins, steroids. You have the examples there. There is nothing new there. Amine made from tryptophan, tyrosine. You have examples. And here we have the pathways of hormone action. Okay, well, we were talking about the difference in the actions of lipid-soluble or water-soluble hormones. What is on the left, you have the lipid-soluble hormone diffusing freely through the cell membrane, okay, binding to receptors, okay, in the cytoplasm, forming a complex. Some of them enter directly to the nucleus and bind to receptors in the nucleus. We're not going to enter into that difference, and activates a transcription, translation, and that cell starts making proteins that will do something else. In the case of the water soluble, they need to bind to receptors. This could be epinephrine, this could be FSH, this could be LH, this could be insulin. Okay, that will activate a second messenger will activate effectors inside the cells that will activate enzymes, and those enzymes are going to lead to different actions inside the cell. Okay, maybe making proteins, maybe cell division, maybe different things.
And generally, the lipid solubles are long-acting, right?
In general, yeah, are more long-acting. And also the one important thing that I don't think is mentioned there, for example, we don't have any way of storing the steroid hormones. Okay? There's no way that we can store them like we do with the peptides. Okay? We have a reservoir. Okay, and it's because if the steroid hormones are hydrophobic, okay, you can't simply send them to the blood like that because they are not water soluble. They need to have a transporter. Okay, steroid hormones, when they go to the blood, they need to bind to a protein. That is, generic term is steroid binding protein. There are different proteins, for example, androgen binding protein. Okay, there is a thyroid hormone binding protein. They can bind to albumin. So they are gonna need a transporter to travel in the blood until they reach the target organs. Peptidic hormones, proteins, they can travel freely in the blood because they are water soluble. You can dissolve them in blood perfectly, in plasma. Now then we have the regulation of hormone secretion. And before going there, let me see something. Yeah. I made the distinction there. I need to make sure. Here we have the regulation of the hormone secretion, which we are going to differentiate from the regulation of the hormone action. Okay, we are talking about how the gland knows how much hormone has to release, for how long, when to stop. This is something that is occurring at the level of the glands that produce the hormones. Okay, that will determine the concentration of the hormone in the blood This has nothing to do with the response. Let's say you can have lots of hormones, let's say insulin in the blood, but if the cells don't have receptors for that insulin, there's not going to be any action. Doesn't matter how much insulin the pancreas releases. Okay, this part here is talking about the regulation of the secretion, the release of the hormone. And the most important mechanism is the negative feedback loop that we studied previously. It's the same negative feedback loop. Okay, here you have examples. We are using the glucocorticoids. Okay, how the body releases or knows how to release, when to release adrenal glucocorticoids. Okay, we have a diagram. You will start with a cycle, so we actually can start anywhere, but I always prefer to start in the hypothalamus. Okay, when we need to release glucocorticoids, for example, if we are under stress, if the blood sugar levels are low, if we are having any type of infection, trauma, inflammation, trauma, or any psychological stress as well, we are going to produce CRH, corticotropic releasing hormone. Okay, that is going to travel to the anterior pituitary, leading to the release of ACTH, adrenocorticotropic hormone, that will stimulate the adrenal cortex to produce cortisol. Okay, that will increase the production of cortisol. Cortisol has many actions. We are going to be studying them more in the future. Okay, so when there is an imbalance, the hormone is either in deficit or in excess. Okay, we are going to have a correction. Okay, that will be either more release of the hormone if it was low, or less if it was elevated. Okay, and then we are going to have a negative feedback that will counteract what happened previously. So stress, CRH, ACTH, increased cortisol. Now we don't have any more stress, and the body determines that there is too much cortisol. Well, by negative feedback mechanism, okay, we are going to suppress the release of CRH, ACTH from the hypothalamus pituitary, but the production of cortisol is going to go down. And the same thing happens for almost every hormone in the body. There are different ways of regulating this. We are going to see the differences. For example, there are hormones that are regulated by very simple reflexes. One example is the regulation of the blood levels of calcium. Okay, what happens if when we have low calcium, okay, reduced plasma calcium levels, that is going to be detected by the parathyroid gland. Okay, parathyroid gland cells, they have a receptor that is called the calcium sensor. Okay, when calcium is elevated, calcium is low, they are going to act differently. If calcium is low, they are going to release PTH, parathyroid hormone. For that release, it's a little detail that we are going to find very useful in the future. We need magnesium. Okay, sometimes we don't understand what's going on with the patients. And it's simply that there is a mineral that is missing, something is missing that is necessary. So when you see that there is no elevation of the calcium, start with magnesium. Okay, you see it's the cause. Maybe it helps, maybe it doesn't, because it's difficult to know in every case. And magnesium is needed for this. And then parathyroid hormone is going to act to increase the calcium levels. How it does it? Many different ways. It activates the osteoclasts in the bone. Okay, it activates the kidney, or tells the kidney to activate vitamin D. We have an increase in vitamin D levels. It tells the kidney to retain calcium, don't let calcium go. Also increases the absorption of calcium from the GI tract. Different mechanisms. It's a very simple reflex. When calcium is elevated, now we are going to inhibit the parathyroid cells, so they don't produce more PTH. And there are some mechanisms that are more complex. Okay, and we go back to the blood glucose regulation. You remember the feed-forward mechanisms. So these are more complex. If you go back to 1988, Okay, the glucose regulation was like this. And I studied, glucose is low, beta cells produce insulin, and glucose goes down. Very easy. Now we are not in 1988. Now we know more stuff. This is the 1988 diagram. Now we have added the incretins. That is another step that helps us understand better the differences between people with type 1, type 2 diabetes, and the differences between people with type 2 diabetes, why they are not always the same. Okay, we take the carbohydrates, glucose in the intestines, gonna stimulate endocrine cells in the intestines that are gonna produce incretins, GLP, glucose-like peptide 1, glucagon-like peptide 1, that is gonna stimulate the beta cells of the pancreas, such that the beta cells can also be stimulated directly by glucose after it is absorbed. Okay, and for either or of these mechanisms, the beta cells are going to make insulin, release it, and that's going to lead to uptake of glucose by the tissues that are insulin sensitive, and that's going to lead to the reduction in blood glucose. Now we have a diagram about the incretin effect, and let me clarify now that we are here. When you prepare for an exam, first of all you have to know what you are studying. Okay, read the learning objectives. Okay, I am studying physiology. I'm not studying pathophysiology. Okay, so sometimes we are going to give you examples of diseases like here. It's simply to illustrate. Okay, this doesn't mean that you have to study diabetes type 2. Okay, we are simply studying the concepts of the regulation of insulin secretion. How do we tell the pancreas to make insulin? There are two mechanisms. Increase incretins because we ate sugar, or increase blood sugar levels directly. Okay, what will happen after insulin is produced? Sugar is going to go down. How? That's for the future. Okay, do we need to understand diabetes type 2? Not at all. Okay, not at all. On the left side, you have the different effects, okay, on different organ systems, okay, that the incretins have. For example, decreases inflammation, increases sodium excretion, okay, decreases lipoprotein secretion in the intestines, increases growth. And this is talking, for example, about the medication. Right, these medications are, everybody wants them now. Okay, in the brain, reduces the food intake, appetite, is neuroprotective, increases neurogenesis, so may increase the amount of neurons, at least in the hippocampus, cardiovascular effects, very good cardiovascular effects, protective effects. Okay, increases or reduces glucagon, increases somatostatin, increases insulin secretion, increases insulin biosynthesis, proliferation, decreases apoptosis. Now, every time there is a new medication with promising results, we have to be very cautious because there are many things that we don't know. For example, stem cells. Oh, we can treat that with stem cells. You don't know what stem cells are going to become. And we hope, we expect that stem cells become the cell of the tissue where you place them. It can become anything. Okay, it can become teeth, it can become tongue, it can become muscle, bone, it can become cancer cells. Okay, in this case, notice, for example, at the level of the pancreatic beta cells, etc., increases proliferation, decreases apoptosis. If a medication induces proliferation and decreases apoptosis, who can guarantee that that occurs only in the pancreas? Do we know? If that occurs only in the pancreas, or may occur in the liver, or may occur in the lung, or may occur in the bone, in the brain. So you have to be very careful, and unless something is really, really medically needed, okay, when someone has a morbid obesity, that they have tried everything and they are at risk of suicide tomorrow, well, you can give anything because we need to save that life, okay? Person who don't need it, it's better not to use it because by using Ozempic, you don't learn how to eat. You may lose 60 pounds in 2 months, but then when you start eating again, you're gonna gain 120 pounds in 2 months. Okay, so we don't talk to the patients like that, but we try to, okay, let's try a method that teaches you how to eat, that makes you develop good habits, okay, that we're gonna remove certain things from your diet, and then we're gonna reintroduce them little by little until you maintain a stable weight, okay, and of course exercise. Because let me tell you, obesity, the only problem besides the aesthetic problems and the social problems, that all these problems that we have with the self-image, the problem with obesity is not the weight, it's the inflammatory markers. All of this adipose tissue that is ectopic in so many places is producing pro-inflammatory, pro-embolic, atherotic cytokines. And if we simply lose weight by doing a diet, only diet, we're going to produce the same inflammatory mediators from the little adipose tissue that we continue having. So we have the same cardiovascular risk. The only way that we can stop the production of pro-inflammatory and start making anti-inflammatory mediators is by exercise. Okay, the exercise, the losing weight only by diet is good from the aesthetical point of view, but not from the health point of view. Okay, so the exercise plus the diet that helps you learn how to eat and develop habits, that is the only one that works in the long term. You don't want to be down, up, down, up, down, up. Okay, that is worse than being all the time overweight, because you are mobilizing fat in, mobilizing fat out. All that fat that is moving in and out is getting deposited in the blood vessels. Okay. And on the right here you have something that illustrates the incretin effect. Okay, you have a diagram that shows someone who is receiving, healthy patients that are receiving an oral glucose load, 50 grams of glucose dissolved in 400 milliliters of water. Okay. And below, okay, we have IV glucose infusion, and we can compare the insulin in the y-axis in time, how insulin levels vary in time. Okay, with the oral load of glucose, notice how insulin increases and peaks 1 hour later at very, very high level. This is what happens, okay, when you simply give IV glucose. Notice 1 hour after, okay, the infusion of IV glucose versus oral glucose, the difference in insulin levels. That means that glucose is going to go down very fast, okay, if we have a very high level of insulin. That distance, that difference between the amount of insulin in response to an IV glucose infusion versus oral glucose is what we call the incretin effect. Now, compared to patients with type 2 diabetes mellitus. Okay, notice that the IV, the response after the IV infusion is very similar to that of people with healthy patients. Okay, they even produce more insulin. The insulin stays elevated longer in time. Okay, one of the characteristics of patients with type 2 diabetes is hyperinsulinemia. The pancreas, they develop what we call insulin resistance, which means for us to maintain the same levels of glucose, we need to produce a lot more insulin. Okay, you have someone who doesn't hear very well, you have to talk really loud to get the same effect. The pancreas is like screaming, please lower the sugar. Okay, so the cells respond. Now notice the response, the amount of insulin that is, the changes in blood insulin levels after the oral load. Very small. They have a very, very, very small incretin effect. And this is either because they don't make incretins or because they have enzymes that break down incretins too fast. So we can give, stimulate the production of incretins or block the enzymes that break down the incretins. That's maybe a trial and error, maybe until we have genetic testing, more things that we can know what is the most appropriate medication for every patient.
Professor, why is there a decrease, why is the insulin production lower for the IV glucose?
Because you don't have the incretin effect. Remember, incretin effect is when you have the oral glucose. You stimulate the taste, the sweet receptors in the duodenum, the jejunum, stomach, and that prepares the pancreas. So that glucose is coming. The pancreas starts releasing insulin way before the glucose is elevated. Now when you have the glucose in the blood, a lot more. It's like pancreas is ready. So today we are going to end with this slide here. That summarizes the regulation of hormone release. I always, when I have to compare stuff, I like starting by the simplest one. And the simplest one is the one that we studied before, the sympathetic nervous system. When we are under stress, we have a signal from the hypothalamus, action potential down the spinal cord directly to the adrenal medulla that will stimulate the cells to release epinephrine. That is a very simple mechanism of hormone release, very fast. That epinephrine will go to the heart, the lungs, everywhere. Now, the one in the center shows what we call the humoral regulation. The first is neural because it's directly by the nervous system. The one in the center is called humoral. Remember, humor means fluid. That is a way of regulation in which the endocrine cells respond to variations in the concentration of different substances in the blood. For example, glucose. Example of insulin. Glucose is high, I produce insulin. Glucose is low, no insulin, I will produce glucagon. Variations in glucose levels. Also, calcium, regulation of calcium and phosphate is another example of humoral regulation of hormone release. If the calcium is low, PTH is going to be released from the parathyroid glands, it's going to go to the blood, it's going to act to increase the calcium concentration, decrease the potassium concentration. Because the potassium, the phosphate. Why is that necessary? Because you don't want calcium and phosphate together, because they're going to bind. If you have calcium and phosphate in the same place, cation and ion, and we don't need calcium phosphate in the blood, we need calcium. So it's necessary for the action potentials, for the muscle contraction. So that is the way of regulation of PTH, insulin, glucagon. And then we have the one that is a bit more complex, that is the hormonal, the first one to the left, hormonal regulation. And simply we have to understand that there are, in most cases, 3 hormones involved. One made in the hypothalamus, another made in the pituitary, anterior pituitary, and the other made in another endocrine gland. That can be either the thyroid, the adrenal cortex, or the gonads. So we have 3 axes. The hypothalamic pituitary thyroid axis, the hypothalamic pituitary adrenal axis, and the hypothalamic pituitary gonadal axis. You have a hormone from the hypothalamus that is called either releasing hormone or inhibiting hormone. For example, corticotropic releasing hormone or corticotropic inhibiting hormone, thyroid releasing hormone or thyroid inhibiting hormone. That's easy to recognize because they will have this name. They will stimulate, for example, thyroid stimulating hormone or adrenocorticotropic hormone, ACTH, or FSH-LH for the ovaries and testes. And these final glands here are going to produce thyroid hormone, okay, cortisol, and are going to produce testosterone, estrogen, progesterone, depending on its pregnancy or phase of the menstrual cycle. Okay, but simply hormonal regulation. One hormone stimulates the release of another hormone, and the other hormone stimulates the other, and that one makes a negative feedback on the first one, hypothalamus pituitary. What makes the negative feedback here? The levels of calcium, glucose. Calcium high, I do this. Calcium is low, I don't do that. Okay, and here, depends on the brain. It's going to stimulate the release of epinephrine. Do we need it? Yes. If we don't need it, we stop. Okay. And well, that's it for this week. Okay, we'll see you next week and have a very happy weekend. Yeah.
Wait, I was gonna ask a question. So before when you mentioned that pharmaceuticals, like if most products on the pharmaceuticals, we have to take into account the bad percentage of the hair. That somebody with a like, I don't think I'm will that make any copy of or I think if that's the way they will, only like 30 minutes. No, it means
Yeah.